Fantastic. Well, I think we can get started. Welcome everyone to Geriatric Medicine Grand Rounds. This is our first Geriatrics Grand Rounds for this academic year. So welcome to all of you who are new to Grand Rounds and to all of you who are returning. Before we get started, I just wanted to quickly introduce our 4 new Geriatric Medicine Fellows before Sam gets started, just so you can put names with faces or names with Zoom names. We have Elise Opheim, if you just want to wave, Jasdeep Kaur, hello, Jesse Malpin, and Drew Hunter. And we're so glad that you are here with us, and we'll all get to know you over the year. All right. We have a Geriatric Medicine Fellow presenting Grand Rounds today. Sam will complete her Geriatric Medicine Fellowship at the end of September, and she's doing her Grand Rounds now. And as I mentioned previously, fellows get to pick whichever topic they'd like, a topic of interest to them, to teach us all about. And Sam is really, really good at taking deep dives in topics and providing fantastic presentations. So I'm really, really excited to hear all about cannabis in the older adult from Sam today. Thank you.
Yeah, Kate, thank you. Hopefully I can live up to your expectations. So I actually first got really interested in cannabis and cannabis products when I moved to Seattle. And the vast majority of my patients that I had at the VA were using cannabis products. And I realized I just really had no idea about anything about medical use of marijuana for medical purposes. And so I went downtown and I went to one of the commercial retailers and met a nice bud tender named Andre, who sort of showed me the ropes and all the products. And I found that to be very useful. And then I also, of course, did a lot of my own research to fill in the gaps. But surprisingly, then when I started Geriatrics Fellowship, not quite as many, but still quite a few of my patients were using cannabis products. And so I figured I definitely needed to update myself on how this applied to older adults, and decided I would bring this information to you as well. So I have no disclosures, except that I will say I have a little bit of a personal bias against cannabis products. I admittedly did smoke some marijuana, but not since like a very, very long time ago. And so I have no experience myself with kind of the new wide world of cannabis in the United States either. So today we'll be talking about the changing cannabis landscape, then some of the cannabis basics, just briefly touch on the pitfalls of cannabis research, and then look at some of the patterns of cannabis use in older adults, followed by evidence for benefit and harm. So cannabis use in the United States really is exploding. It has been legalized in 15 states in the District of Columbia, and there are currently 3 states that have pending recreational marijuana legalization. Additional 17 states have medicinal use only. And a lot of the other states have more narrow laws or have even decriminalized possession. So it's just getting broadly more acceptable. Notably, it's all still illegal at the federal level, although Chuck Schumer, the Senate Majority Leader, is introducing legislation to change that. And that is something that has just developed over the last couple of days. Important for our purposes is that cannabis use is increasing in older adults faster than any other age group. So this is some data from the National Survey on Drug Use and Health, which is a representative survey of community dwelling adults. And this looked at the subset of persons 65 years and older. And you can see here that from about 2007, 2008, we go from less than 1% use to over 2% use by the time 2015 rolls around. And then in this graph, we carry that through from 2015 to 2018, where use increased from 2.4% to 4.2%. Slight male predominance, such that almost 6% of men over the age of 65 in the US are using cannabis products, compared with about 3% of women. But that was in 2018. We don't know what's been going on in the last couple of years. And then interestingly, the use has been increasing more in those with higher education and income. So a population that probably is going to be coming to us and wanting more information. So here in Washington State, cannabis was decriminalized in 2012. And it wasn't really until about 2014 that things got up and running. That's when the retail stores were licensed and could begin operating. So this was a study that looked at trends in cannabis use in Washington State after legalization. And this was a cross-sectional study that was done with random phone dials, cell phones and landlines at different time points between 2014, actually January 2014 to October 2016. And they had a pretty good response rate. So about 1,000 per age, 1,000 per time point, but they looked at people who were age 50 and over. So this isn't strictly older adults, but in the older population, those who had cannabis use in the past 12 months increased stepwise from 15 to about 21 to about 24% in 2016. So this is reflective of the national trend here locally. Now, I think one reason that the cannabis use has become more popular in older adults is because there has been a reduction of the stigma that's associated with use, which seems to be largely driven by medical marijuana and the publicity surrounding medical marijuana. This was a nice paper that was done in Colorado, and they were assessing attitudes about cannabis use in older adults. So they did a series of 17 focus groups with well over 100 participants, a mean age of 72. They recruited individuals from places like senior centers and other places that older adults typically go. And what they found was that even if people weren't using marijuana products themselves, they typically favored marijuana use for medicinal purposes. And about 70% of older adults believed that they should be educated about cannabis. And moreover, they really wanted to get this information from their regular medical providers. And so I think it's really important that we are able to provide that information to them that they want. So we're going to talk a little bit about the basics of cannabis. So it has been around for a very long time. So at least 10,000 years it's been cultivated. It's used a lot in Eastern medicine and Western medicine. It's one of the staples in Eastern medicine, actually. And in Western medicine in the 1800s, it was used for a very broad variety of medical conditions, tetanus, epilepsy, and mental disorders most commonly, but really there weren't a lot of options. So if you had a medical problem, often they would throw marijuana at it. And marijuana was even included in the Pharmacopoeia of the US until 1942. So the movement against marijuana is really interesting. It followed the Mexican Revolution, when there were a lot of Mexican immigrants who were coming into the United States. And there was a fear of the Mexican immigrants and these other people that we don't know, and they're taking our jobs, which sounds a little bit familiar. And a lot of those immigrants tended to smoke marijuana. And so they demonized the marijuana products in order to demonize the Mexican Americans. And most of the states in the United States outlawed marijuana in the 1910s and 1920s. And then the federal government, with the Marijuana Tax Act, outlawed it in 1937. And the first commissioner of the Federal Bureau of Narcotics, Harry Anslinger, really led this crusade to get rid of marijuana, used a lot of propaganda to scare people, to assert that marijuana caused really violent behavior and psychosis and hypersexuality. And a lot of those attitudes, rightly or wrongly, carried over through the years until more sort of recently, within the last 10, 20 years, when attitudes have been changing. And interestingly, when the feds did that, it was physicians who opposed the federal regulation at that time. So if we talk about the cannabis plant, the genus and species is Cannabis sativa, and there's two different strains. Sativa, which you'll see here, it's a much taller plant, and indica, which has thicker leaves, and it's a shorter plant. So they do have some morphological differences, and they are thought by marijuana connoisseurs to also produce different kinds of highs. So sativa is associated with a more uplifting and energetic high, more psychoactive effects, whereas indica is thought to be a more chill high. In reality, though, there's been such extensive crossbreeding that you can't tell the difference between the two strains based on morphology alone. And even if you did know the biochemical profile that you were looking for, you would need to do laboratory testing to really tell the difference. So the active substances in marijuana are the signaling molecules cannabinoids. You can see they look very similar. Cannabidiol, or CBD, is the first one, and it does not actually have any psychoactive effects. It's thought to have more anti-inflammatory and neuroprotective properties. And when it binds to its receptors, it actually binds with low affinity or even negatively modulates those receptors. So we contrast that with THC, which is the psychoactive component of cannabis products, but it is only a partial agonist of receptors. And the receptors that I'm talking about are the cannabinoid receptors. So CB1 and CB2 are the main ones, and they are present pretty ubiquitously through the body. They modulate a lot of different signaling cascades that are taking place in physiologic processes. Some examples include pain, inflammation, metabolism, neurotransmission, and appetite. And if you think about the uses that people are typically using cannabis products for, it's really reflected in their physiologic activity of what's called the endocannabinoid system, or the endogenous cannabinoid system. I will just briefly point out that there are some synthetic cannabinoids, and these are just illegal street products. Their two common names are K2 and Spice, and they bind the receptors with very high affinity and efficacy, unlike CBD and THC. So there was a news story quite a while ago now about a guy in Florida who tried to eat somebody else's face off, and that was under the influence of synthetic cannabinoids. So they do cause some pretty unwanted side effects, psychosis, etc. But marijuana is not just THC and CBD. There are a whole host of other compounds in there, like with any plant. A lot of terpenoids and flavonoids. So terpenoids are what give the marijuana its characteristic smell and taste. And the terpenoids are thought to modify the effect of THC and CBD. Flavonoids have plant pigments, and they are thought to have some antibiotic properties. So lots of other stuff that's going on in the plant. And if anybody has questions, please feel free to ask them as I'm going. That's just fine. So this was interesting to me to learn what was available on the market, because I just had no idea. So you got your traditional joints. These have an immediate onset because they're smoked, and the upside of these is that they're very easy to titrate. They all have pretty high THC and lower CBD. With edibles, the standard dose is 10 milligrams of THC, sometimes it's 5, usually higher for CBD, like 75 to 300 milligrams. And that's what's used in research also. And the thing to know about these is that it takes a little while for the effect to be seen. So 30 minutes to 2 hours, and then it lasts for a while. And what can happen with this is, I was warned, with inexperienced users, they'll think that nothing is happening, but they just haven't waited long enough, and then they'll take more, and then they'll get this compounded effect, and then they'll end up having taken way more than they needed to and being really uncomfortable. tinctures are cannabis infused alcohol, and they can be used like an edible, either PO or sublingual, which, like other sublingual medications, has a shorter onset and duration of effect. A lot of my patients use topicals, which can have CBD and or THC, and they just act locally, sort of like menthol salicylate. If your patient is using a patch, you'll need to warn them that that is not like a lidocaine patch. It doesn't act locally. Those are like fentanyl patches where it delivers the drug systemically. And then finally, cannabis oil. So our patients typically won't be using these. These are purified cannabinoids, and they have very high concentrations of THC, but they also can be CBD. In the non-medical setting, people tend to dab, and sometimes in the medical setting, you might see people using vape pens, but like joints, these also have an immediate onset and are easy to titrate. So a lot of my patients are wanting to use CBD only products, and I always keep this study in mind. So this was a very nice study that came out of JAMA in 2017, where they looked at a number of different products that were labeled as pure CBD. And then they checked the accuracy of the potency labeling. And what they found was that 42% were underlabeled, 26% were overlabeled, and only a third of them were accurately labeled. So that's all well and good, but I think the most important point of this study was that 20% of the samples actually had THC. So when somebody's buying a pure CBD product, it's usually because they don't want that hallucinogenic effect of the THC, but they might be getting it unwittingly. There's also some cannabis pharmaceutical products, and we'll talk about some of those in the FDA approved uses. So dronabinol is probably the one that we're most familiar with, and that can be, the trade name for that is Marinol. And this is a synthetic THC that is FDA approved for nausea vomiting of chemotherapy and also to stimulate appetite, but only in AIDS patients with wasting syndrome, not in other conditions. Nabilone is a synthetic cannabinoid, or it's a THC analog, and it is approved for nausea vomiting of chemotherapy. So interestingly, this is no longer made, and I don't believe it's available in the US because it was marketed under the trade name Sesamet, and they are no longer making that. And so I was not able to find any other formulation of Nabilone that would be available in the United States. So I don't think that we can actually get it right now. Nabiximol is not available in the United States at all. It's a CBD and THC extract that's a 1-to-1 ratio. And the main reason this is not available in the United States is because the FDA really has been loath to approve narcotics that are illegal at the federal level. And so this is available in Europe, Japan, and Canada. It's approved for spasticity and MS, also cancer pain, although I will tell you there is no evidence that it is beneficial in cancer pain. And then Epidiolex, which is approved in the United States, and that's sort of a more recent development in the last couple of years. And this is a concentrated CBD oil that is approved only for intractable epilepsy, but it actually works fairly well for that. So now let's talk about patterns of cannabis use in older adults. And there were two nice studies that came out that talked about this, and they're very, very similar. So this first one was a survey that was done at some senior primary care clinics in Colorado in 2018. And individuals who were coming in for their regular primary care appointment completed a survey when they were checking into clinic. This survey did exclude persons with cognitive impairment or people who don't speak English. So, adapt this and think about how it might apply to your patient population. I'd say the one downfall of this study is that there was only a 55% response rate. So certainly I think there was some participation bias present. But they found that 30% of the patients had ever used cannabis products, whereas 16% were considered current users, but they considered current users to be using within the last 3 years. So if we look at the age breakdown of the patients, in this population, it was pretty consistent across all age groups. I think I might have expected it just by my bias to be a little bit more heavy on the younger side, but it wasn't. It was pretty evenly distributed. And then in terms of education, tended to be more on the high side, although there was a small proportion of people who didn't have a high school diploma anyway. So, and then this is the really interesting part. So about a third of users were using marijuana daily. And when we look at what products they were using, over half were using edibles, or using it orally. So 42% with edibles and then an additional 9% with pills. And then a third were smoking it using smoking joints, and a third were using topicals. And then what were the top symptoms that were targeted with use? Pain overwhelmingly, and followed by sleep, anxiety, and depression. So let's compare this to this second study. This was done in 2020, and this was some surveys that were done at 2 primary care clinics out of UC San Diego. Just like in the prior study, the surveys were completed at check-in, but they did not have any exclusion criteria, at least that they described. So they had an excellent response rate. I would love to know how they managed that, but they had a 95% response rate. And what they found was very similar to the Colorado group. So about a third had ever used cannabis products, and about 15% were considered current users with the same definition of using within the last 3 years. Oops, sorry. And this population is a little bit heavier in the middle side, but definitely all ages using. And then here, heavily weighted toward 11% using with high school or less, 43% with college degree or some completed college degree, and 46% with graduate and or advanced degree. All right, when we look at use frequency here, again, almost 40% using marijuana daily. And then they have a couple of other interesting things in this study that they didn't have in the prior study. So they break it down by the type of products that were being used, and almost half were using CBD only products, although an additional 14% were really sure what they were using. 80%, about 80% were using for medical purposes only 7% for recreational purposes only, and 15% for both. Although certainly they may not have been telling the truth about that. And then when we look at the administration form, about a third were smoking it here, just like previously. They divide up all of the edibles into many different things, but edibles, or the PO could be edibles, tinctures, and pills. So over 50%, and then also about a third here using topicals. And then when we look at the indications for why they were using it, it's actually exactly the same as with the Colorado study. So overwhelmingly people using it for pain, followed by sleep, anxiety, and depression. So both studies show that older adults use most for pain, followed by sleep and mental health. The patients tend to be well educated. About 30% are daily users. Patients largely are using edibles, but they're also smoking it and using topicals. Based on the second study, maybe almost half of patients are trying to use CBD only products, and there's potentially low recreational use. So I want to briefly just touch on some of the research issues that people might not be aware of. So there has just been an explosion of research that's been done on cannabis, and most of it has focused on the pharmaceutical products. A lot of the research has been done over in Europe as well. And the reason for that is that there are a lot of barriers to doing research on the full cannabis flower. You have to get approval from multiple government agencies, fill out multiple applications. It's very time consuming and almost sort of not even worth it. And then the product that you do use, it has to be purchased through the National Institute on Drug Abuse, and they have a stock grown at the University of Mississippi. And there's no biochemical profile that is published about this. They do say what the THC and the CBD is, but we do believe that the other compounds that are in the cannabis may modify the effects of the THC and the CBD, but they don't provide any of that information. Also, the research products are not really reflective of what the commercial products are. So our patients are getting the commercial products, not the research products. And NIDA, the potency of THC is about 3.5 to 7% with a maximum of 12.4, whereas there was a study that looked at the potency of THC in commercial cannabis flower in Colorado, and it averaged about 18.7%, but was up to 35%. And then there's no potency limits for concentrates and ingestible products. Also, the placebo is really inadequate. So when they've done studies of whole flower, and then they go back and they ask the participants if they thought they were in the placebo or the drug group, pretty much overwhelmingly people know which group they were in. And it's just because the placebo is nothing like marijuana flower at all. So now we'll dig into the evidence of medical benefit of cannabis. I will say that I wish that this part was more exciting than it is. So I'll just warn you up front that there's a lot that we don't know. And I'm only going to be really talking about randomized controlled trial data. And the reason for that is that people just love their marijuana products, and observational studies tend to be exceptionally positive. And so I just such a huge risk of bias, and because they're so also overwhelmingly positive, they're really not worth discussing most of the time. So number one indication in older adults, or why they're taking it, chronic pain. And there have been a number of like reasonably okay randomized control trials, and also a number of meta-analyses. And primarily neuropathic pain has been studied, but also other etiologies, arthritis, cancer pain, etc. Most of these studies have used nabiximols, which is the THC CBD extract, which is not available in the United States. Some have used pure THC, nabilone has been used, and then a few have used cannabis flower. Interestingly, none have used CBD in isolation. And I feel like I have a lot of patients who use CBD for pain, but it just really hasn't been adequately studied. So patients do appear to have some improvement in pain symptoms. So 30% reduction, which would be considered clinically significant. And the number needed to treat, depending on the study, is 3 to 20. But again, our data primarily is for neuropathic pain. And really, even though nabiximols is approved for cancer pain, there is no evidence of benefit for cancer pain. So on the other hand, a significant proportion of people stop treatment due to the negative side effects. And I have a whole section about side effects and harm, so we'll cover it then. But the number needed to harm is 3 to 10. So that's fewer people than the number needed to treat for benefit. We don't have any head-to-head trials against other analgesics. And then we don't know how the products, like I mentioned before, how the products that our patients are actually using compared to the products that were tested, or if they are reflective at all, and if we can extrapolate this data to what they're getting on the commercial market. And then there's no trial specific to older adults, although in the chronic pain world, most of the participants are in their 50s and 60s. So starting to get older, but nobody in their 70s and 80s typically participates. I will say that there is a silver lining to this, and that is that states that have legalized cannabis have seen a reduction in the number of opioid prescriptions and opioid-associated deaths. And that's just epidemiologic data. All right, our patients are also using it for mental health. So with respect to anxiety, the data is just doesn't really exist. So most of the randomized controlled trials looking at anxiety have just looked at anxiety as a symptom in the setting of other conditions, and not in adults who have a formal diagnosis of an anxiety disorder, although there have been a few specific studies in social anxiety disorder. They've looked at CBD, nabiximols, and nabilone. And it does seem like the THC preparations reduce anxious symptoms, but this has been found mostly in the setting of other chronic diseases. So not in the setting of a specific anxiety disorder. There is one trial that's going on right now looking at generalized anxiety disorder. And there aren't any trials that have specifically looked at anxiety in older adults. And then older adults are using it for depression, which I find curious because there really isn't any evidence that marijuana helps depression. It doesn't seem to cause depression, but there is a signal of worsening existing depression in people who have depression and are using marijuana. And then I know there's been a lot of interest in cannabis to manage PTSD. And a couple of years ago, there were some big RCTs that were started. And so I was very interested in some of the data that would be coming out, but those haven't been published or haven't been finished. The data that I have seen was mostly looking at people who had PTSD, who smoked a lot of marijuana. And it seemed like their PTSD symptoms and their anger symptoms improved when they stopped marijuana. And in general, most of them, there are a number of different position papers that have come out from various associations that have said that marijuana should not be used for mental health issues. The last top use in older adults is insomnia. So there have been multiple randomized controlled trials that have looked at cannabis in chronic illness with sleep as one outcome. So sort of like with the anxiety situation. And there has been some low quality evidence for benefit in sleep disorders that are associated with chronic illness. There have been just a few that have looked at cannabis use in primary insomnia, but very few older patients. And all of the studies have a very high risk of bias. So THC, nabilone, and CBD have been tested, and there's some low quality evidence that there might be some benefit. So maybe some benefit, but the side effects are similar to other sleep aids. So grogginess, dry mouth, confusion, etc. And so I would assert that this is probably no better than any of the other prescription sleep aids that we already can prescribe and don't like to. Nausea, vomiting, and chemotherapy is an FDA-approved use for cannabis products, and there have been a lot of studies looking at this. Most of them have used nabilone or dronabinol, and none of them have used whole cannabis plant. So the results are generally mixed. Cannabis products generally perform better than placebo, but not always. And the effect is largely equivalent to other antiemetics, but with more side effects. And people are actually more likely to discontinue the cannabis products than other antiemetics. And really, if you think about it, other antiemetics have a lot of side effects. So metoclopramide, compazine, promethazine, all of those do not have a great side effect profile. And then CBD, which has a much better side effect profile than THC products, has not been investigated. Moving on to appetite and weight gain, there are not a lot of studies that have been done. There is evidence that marijuana products increase appetite and weight gain, specifically in HIV wasting syndrome. There have been a couple of studies that have shown that. There's no evidence of increased appetite and weight gain in cancer. There has been some benefit in observational studies, and there was a pretty good randomized controlled trial of THC CBD extract that was negative. And the reason people thought that it might increase appetite and cause weight gain is that there were some small studies that were done in the 1970s and 80s where smoking marijuana increased caloric intake by 40%. And so this is what is referred to as the munchies, but it does not seem to apply to necessarily apply to older, sicker adults. It may just apply to younger, healthy adults. There also is speculation that it might be a different compound that is in the marijuana plant that is causing the increase in appetite. And so that might be why we're not seeing the effect in the studies that have been done. There was a lot of popularity when medical marijuana first was on the scene with using it for glaucoma. And I'll just briefly touch on this. So marijuana products do reduce intraocular pressure 10 to 30% with oral or inhaled THC products, so specifically THC products. But it lasts only about 3 to 4 hours and patients build a tolerance, and then the oral formulations just stop working altogether. So they've tried CBD. There's no effect with CBD alone. You'd have to have the THC product, and topical formulations don't work except in one study, which showed a huge reduction in intraocular pressure in both the THC and the placebo groups. So I don't think that was probably valid. What I will say, though, is that there is an endogenous cannabinoid that they have been studying in pill form, PEA, and this does show promise for working for glaucoma. It is not a psychoactive medication, and so we, in the coming years, might find that on the market. All right, moving on to some other very Geri-specific illnesses. So Parkinson's disease. I have patients asking me about cannabis and Parkinson's disease all the time. And the rationale for, so Parkinson's disease is thought maybe that it would improve motor symptoms. And the rationale is that the endocannabinoid system in the striatum rearranges after dopamine is depleted. And that's been found in animal models. So they've postulated that cannabinoids might modulate dopamine activity or provide neuroprotection. So there have been 6 randomized control trials that have looked at the effect of cannabis products on motor symptoms of Parkinson's disease. They've studied CBD alone, NAB alone, or other synthetic cannabinoids, and ones that aren't available on the market, ones that are just being tested. So one of these studies showed reduced dyskinesia, but other studies showed no benefit. And I guess what I should say is that these patients were also on their standard therapy, like if levodopa, carbidopa, or other dopaminergic medications. And there was a pretty high rate of side effects, so 25 to 50% of people had side effects, but interestingly, most of them were low grade and not bothersome enough to stop the drug. So this was a meta-analysis that looked at the change in UPDS motor scores based on 3 of the RCTs, and here you can just see that they showed that there was no difference. So I would say pretty conclusively, it does not seem to have any benefit in Parkinson's disease, and you can probably tell your patients that. And then behaviors of dementia is the next Geri-specific indication. And the rationale behind this is that the CB1 receptors that are in the limbic system have been linked to the neuropsych symptoms of Alzheimer's disease and aggression. And just a second, my screen's okay. And there have been 6 randomized control trials. I say about 6 because one of them was the same clinical trial, but it was in 2 stages. And so it was sort of considered 2 different trials, but it wasn't really. They all had really small sample sizes. So the largest was about 40 or so, but typically they were in the 10s and 20s. There was no benefit found with the THC products, like the actual, like either purified THC derived from the plant, and CBD was not tested, CBD alone not tested. And then there were some studies that showed mixed benefit with synthetic cannabinoids, so dronabinol and nabilone. In general, these patients were in their 70s and 80s with Alzheimer's disease, and it was in 5 of these studies, it was tolerated really well, but most of the studies were likely underdosed. So they were using like 2.5 of dronabinol once a day, or like 1 milligram of THC, and the standard dose is 5 to 10 in an edible. So I'm going to go over this study because I thought it was the most well done and the most interesting. This was what they did was they recruited a bunch of patients from Alzheimer's disease patients from either skilled nursing facilities or outpatient geriatric psychiatry clinics. So probably reflective of the patients that we're all taking care of. And the inclusion criteria was that you had to be 55 years old with Alzheimer's disease and have clinically significant agitation or aggression. So the study design was that it was a double-blind 14-week crossover trial. So everybody would do 1 week of placebo and then start either your placebo or nabilone phase for 6 weeks, and then do another week of placebo and then do crossover to placebo or nabilone for an additional 6 weeks. And the primary outcome was agitation, and this was measured by the Cohen-Mansfield Agitation Inventory. And then secondary outcomes were cognition per a standardized version of the MMSE, neuropsych symptoms and caregiver burden per the neuropsychiatric inventory, the nursing home version of that, and then a scale called the clinician global impression of change. So just the clinicians subjectively rating how well they thought the patient was doing. So they enrolled 39 patients, but one withdrew due to delusions during the week 1 placebo. So at the end, there was 38, 2 of them died, one in the placebo phase and one in the nabilone phase, and 9 ended the study early due to adverse events, but 4 in the placebo phase and 5 in the nabilone phase. The mean age of the participants was 87, and then the baseline MMSE score for them was 6.5 with a standard deviation of 6.8, so pretty advanced dementia. All right, and this is the main result. So you can see the trend over time through the 6 weeks on either nabilone, which is here in the red, compared to placebo, which is here in the blue. And there was a statistically significant difference in agitation score, so lower being better at week 2 and week 6 in the nabilone group. And then when we look at the clinician global improvement of change, 47% were perceived to have improved in the treatment phase compared to just 23% perceived to have improved in the placebo phase. In addition, the caregiver burden and neuropsych symptom scores improved in the nabilone phase. However, the mini mental status exam scores favored placebo, so they went down in the nabilone group. When we look at treatment adverse events, so 31 had events in the nabilone group, 14 in placebo, mostly sedation, and that is kind of what we see across the board, is that people have a lot of sedation with this medication compared to only 6 in the placebo, but only 5 had treatment limiting sedation compared to 1 in the placebo. And then when we look at adverse events, it was the same across groups, but 2 patients had lethargy here, 1 died in each group, but there was a critically high INR and a myocardial infarction in the nabilone group, which does follow some of the known effects of cannabis, which I'll talk about in just a moment. But when we think about antipsychotics, they have a lot of bad side effects too. So increased mortality and somnolence are big issues. Some have extrapyramidal side effects, and cognition also flavors placebo in antipsychotic RCTs. So I think this is just definitely worth studying some more, because it might be another tool that we could add to our toolbox for managing the behaviors of dementia, although I think it's certainly not ready for prime time. So the last thing we're going to talk about is the harms of cannabis in the older population. And I will just say here again, there's a paucity of evidence. So I am probably most interested in how mental health and cognition are affected in older cannabis users. So we did note that in that dementia study, the mini mental status exam scores went down in the cannabis product group. This was a review that searched all of the various studies looking for cognitive and psychiatric effects, but usually those are secondary outcomes. They're not something that is studied as a primary effect. And so this review looked at 7 studies, 3 RCTs, a survey, and a prospective observational study, and the mean age was 50 or older. So that really was all that they were able to manage, because most of the studies are with older adults or with adults who are much younger. All of the products studied had both CBD and THC, and then the studies were problematic. So a lot of them excluded people with underlying mental health diagnoses. Some of them, in some of the studies, you already had to be tolerized to the cannabis product. So there's about a 20% dropout rate initially. So it included, it's looking at side effects in patients who are already tolerized to cannabis. And what we see is that there's sort of a whole host of expected side effects: anxiety, confusion, memory issues, some hallucinations, panic attacks, and psychosis. The psychosis was mostly seen in Parkinson's disease patients. But I think the bottom line is that there are concerning psychiatric and cognitive side effects that occur in 15 to 20% of users with an average age of 50. So could be higher in an older population, but overall the quality of the evidence is really low, and we just need to do more investigation. Another thing we worry about with older cannabis users is falls. I have a patient who I see for falls at the VA, and he just won't stop smoking his marijuana. So this is not a great study, but I think they're kind of on the right track. So they looked at things that they test associated with risk of falls, and they recruited 8 users of cannabis from the Iowa Medical Cannabidiol program. They were using almost every day, about 1 to 2 times a day, pretty much all THC products. And then they compared them to 8 sex and age matched non-users, age 50 to 80. And the mean age was 60 here. So they excluded people who had other substance use issues, and then they underwent a series of balance, agility, gait, and cognitive testing. What they found was that the overall fall risk was higher in cannabis users. The balance scale, this is actually measuring how well you could stand on 1 foot for 10 seconds. This was worse, and these are all predictors of falls. And then gait velocity was slower in cannabis users. Of course, they didn't control for any confounders, and it was a very small sample size, but I just like to present this because it's really the only data that we have on this, and I think it's really worth studying a lot more extensively in the future. With respect to driving, we know that acute intoxication with cannabis impairs cognitive and motor task performance and worsens driving. There's also some evidence that regular users may have worse driving even when they are not intoxicated. And epidemiological data has showed that there's an increasing presence of cannabis in people who are involved in motor vehicle crashes, but we don't really know anything specifically about how cannabis use affects driving in older adults. So this also is not the greatest study, but it's the best that we have. So this was the Long Road study, which was a prospective cohort study of older drivers trying to look at factors associated with safe driving. So all of these people at baseline were pretty healthy, driving at least once a week, spoke English, and didn't have any cognitive impairment. So maybe it's sort of a limited generalization of this population. And then they took the subset of 600 Colorado participants for evaluation, and they had been recruited through primary care clinics in the Denver area. They filled out a ton of questionnaires. It seemed a little strange to me to be assessing driving with a bunch of questionnaires, but they've actually shown that the questionnaires correlate with actual highway driving. And then they define cannabis users as having used marijuana at least once in the past month, or 12 months, sorry. What they found is that 10% were classified as cannabis users, although they didn't give any data about the frequency of use or the products that were used. So it might have been that they used a salve once in the last 12 months. 10% reported using within 1 hour of driving, but again, we don't know which products they were using. There was a small significant association between cannabis use and driver errors. That was thought to be mediated through increased anger symptoms. So if you controlled for anger symptoms, then that association went away. So unclear if cannabis use was causing that anger, if people who are angry just tend to use cannabis. But interestingly, no increased risk of crash. So definitely we can do a better job of building on this information so that we can better inform our patients about the actual risks. I don't think many people think about the drug-drug interactions of cannabis, but they are there. So THC and CBD are metabolized by the cytochrome P450 system in the liver, which craps out a little bit as we get older. And CYP2C9 and CYP3A4 are the two main ones. And they metabolize a lot of drugs that we take. So ARBs, calcium channel blockers, NSAIDs, various antidepressants, statins, except rosuvastatin, warfarin, etc. We don't have any studies of interactions between cannabis and medications in older adults. We do know that CBD increases warfarin blood levels. So if you think back to the Alzheimer's study, one person in the nabilone group had a super therapeutic INR. It might have been because the nabilone was interfering with metabolism of warfarin. And then just some brief hits on some health risks, other health risks that people might be interested in. So it seems pretty unlikely that marijuana causes lung or head and neck cancer. There is an association with an increased risk of myocardial infarction with acute cannabis use, but not chronic. With respect to the lungs, it makes sense that we would be concerned for developing or worsening COPD or asthma in really heavy users, but we actually don't have any evidence of that. And marijuana is also thought to have a lot of anti-inflammatory properties. So I wonder if to a certain extent they sort of cancel out. We do know that if you have a lot of chronic cough and phlegm production, if you stop using marijuana, then that improves. And then there's always a risk for fungal infections. Aspergillus likes to grow in the cannabis plants or likes to hang out in the cannabis plants. And that's more of a risk for people who are immunosuppressed, but certainly anyone who's smoking marijuana might be at risk. And then a very gerry-specific concern, so periodontal disease. So marijuana causes a lot of dry mouth and it causes tooth decay. And this effect is multiplied when you have concurrent cigarette smoking, and epidemiological data shows us that a lot of marijuana smokers tend to also be cigarette smokers. So I'll just briefly go over the summary of benefits and harms. So it looks like there is some benefit of chronic pain, nausea, and vomiting of chemotherapy. Likely no benefit or not particularly promising in motor symptoms of Parkinson's disease, mental health, appetite and weight gain, and general conditions, except in HIV and cancer pain. And then promising but needing more data, I think I would put insomnia, PEA for glaucoma, and agitation and Alzheimer's disease in that category. And then the harms, as far as we can tell, worsening cognition, psychiatric side effects, fall risk, impaired driving. Don't forget about drug-drug interactions, periodontal disease, and immediate risk for MI. Although often it's tolerated better than expected, but often those studies are underdosed and causing no therapeutic effect either. So in some, marijuana use has grown quickly in older adults. It's most often used for pain, sleep, and mental health. Edibles are most commonly used, but also topicals and joints. Many patients want to use CBD-only products, but remember, not always accurately labeled. Importantly, the cannabis research products don't reflect the commercial products. We think that cannabis is useful for chronic pain and insomnia, potentially other things, but the side effects can be intolerable when it's at therapeutic doses. And then look out for drug-drug interactions for sure. In general, this is like the end of every talk. More research is needed, but specifically, we need that to better define the benefits and harms of cannabis use in older adults because there is sort of a paucity of data. And that's all there is. These are some of the references. If anybody's interested in any of the papers, I actually have many papers, and I'm happy to provide those. So thank you so much for letting me talk to you.
Thank you. Thank you very much, Sam. David, you put a long comment in the chat, and I was just wondering if you wanted to share that. Sounds like there are some exciting things happening.
Yes, thank you. This is really a wonderful talk on a rapidly developing field. And I just wanted to mention that on the subject of cannabis and dementia, that there is a multi-site center that is beginning to get started now. And I see Dr. Terry is on the call or on the talk as well. But we're not ready to recruit subjects, but we are beginning to reach out to potential providers and hospices in the area who may be seeing these folks who have agitated dementia, who are already in hospice or who are hospice eligible. And the problem is we don't have great treatments for this condition. And as Dr. Hersrud pointed out, the available treatments for agitation are fraught with side effects. And so we will soon be getting up and running, and we invite you to reach out to us for more information as it becomes available. There's no firm protocol yet, but the draft protocol will be available soon. So it's early days, but we are hoping to find partners in the community. So I've put my contact information here in the chat if you're interested.
Thank you so much, David. That's really exciting. Are there any other comments or questions from other folks before we wrap up?
Hey, Kate, this is Annie. Great talk, Sam. That was awesome. I just, think it's so important for us as geriatricians or as primary care providers to be able to talk about this subjectively with our patients, because when they go to the dispensaries, the bud tenders and the folks selling the products will tell you that there's tons of research, positive research, all coming out of Israel about how effective and how beneficial all of these products are on all number of symptoms that they're struggling with. And as Sam already pointed out, like the actual research that we can turn to that's evidence-based is really quite limited, because so many of these studies coming out of Israel are completely problematic. They're all survey-based. There's no control. There's no placebo. Some of them do have placebo, but again, it's, these products are just so unregulated as far as, and people are taking so many different things that it's hard to actually control for anything. So we just have to be aware of what the actual evidence is, and then what folks will be telling our patients the evidence is.
Thanks, Annie. There's a question from Nora Burtis about, can you see the comments, Sam?
Yeah, so asking about marijuana triggering psychotic episodes. So yes, there is some data, there is some evidence that it may unmask underlying psychotic disorders. And I don't think that it causes it, but just that it unmasks it. That is all done in much younger populations, but there is evidence to support that, yes.
Great. Well, I think we're right at the hour. Thank you so much, Sam, for this talk, and thanks everyone for your great comments and questions at the end here. Have a good weekend, everybody.